Thank you very much, George. You covered the very important points very clearly. And as you said in your presentation, the practice is so variable across the board. It's good to know how someone as you, with a very established and highly regarded practice, undertake management of these patients. If I may, first of all, ask you questions on your presentation and then some general discussion regarding Chiari, if that would be okay with you.
Sure, no, absolutely. Happy to.
Thanks. In the case of the asymptomatic syrinx that you had, which went pretty low down the thoracic spine, when you did the foramen magnum decompression, did that syrinx resolve or get small, or the patient get any better?
Yeah, so he was asymptomatic, and after the cervical medullary decompression, there were no complications. Within on a 3-month scan, that syrinx was 50% smaller. On the 6-month scan, it was 85% smaller, and I think at a year it resolved. And I think again he presented with scoliosis. I think we got him early enough. He was one that he did not need an orthopedic procedure to correct his scoliosis. Now, what percentage of children that you do this decompression on will their curve improve? Will it stabilize, or will continue to progress? We looked at this in one of our papers, and I can tell you that you're not going to prevent if a child presents with a 50-degree curve, Chiari malformation, and the sternocleidomalia. Doing the decompression is unlikely to make that curve improve dramatically. I think it does benefit the children that are on the borderline of whether or not they need to proceed for surgery. That, I think, is reasonable.
But even if it is greater than 50 degrees, even if it would not improve, you would operate to stop getting it getting worse, I would imagine. Is that right?
Yes, definitely.
Thanks.
I would definitely recommend surgery. And the reason for that is, for some of the, I think, I haven't seen it for the Chiari malformations, but I've seen it in the intramedullary spinal cord tumors with a large syrinx where they've had fusion surgery, and these patients, during the correction of their scoliosis, have woken up paralyzed. Mm-hmm. And then they've obtained imaging, found a large syrinx with a small tumor, a benign tumor, and I've also seen it in some children where they've broken the rods, and then they've done the imaging and they found that they had a syrinx and a small tumor. So I think that again, I can't. Does one lead to the other? I'm not sure. These are just anecdotal. But I would recommend, before undergoing any orthopedic correction surgery, if there's a syrinx, I would recommend definitely, and there's a known Chiari with syrinx, I would definitely recommend the Chiari decompression.
Thanks. In that case that you showed, the syrinx was obviously very extensive and the patient had scoliosis. When the syrinx is smaller and the patient is asymptomatic, would you still do the operation?
No, I think if it's a very small syrinx, mm-hmm. that's where I think conservative observation is reasonable. Mm-hmm. And again, what's small? I think for me that small is probably 5 or 6 millimeters and smaller. Anything above 8 to 9 millimeters, I think that's a large syrinx that surgery is indicated.
Mm-hmm. If I just may take you from the beginning, in the sense that in terms of working up these Chiari, children with Chiari malformations or syrinx, when patients have BIH, usually patients go through the neurologist and come to us, at least in the UK. And do you see that patients with Chiari, whether they should have more of a multidisciplinary assessment to look for other causes of the problem? What I'm trying to allude is whether patients with BIHs are missed or patients with metabolic diseases causing craniocervical anomalies getting missed, or do you think that just neurosurgeons is assessing them from the beginning is enough?
I mean, we here typically, we assess them from the neurosurgical perspective. If there's any concerns or questions, then those are there's a small subpopulation that may benefit from the multidisciplinary approach. I think you can do it two ways, but there's no right answer on that.
Mm-hmm. And in terms of the Chiari malformation, when the tonsillar descent is not obvious and there's a small syringe, this Chiari 0 or Chiari 0.5, 1.5, they are pretty confusing. But how much do you believe in the crowded craniocervical junction without an obvious tonsillar descent?
I think there's been several papers on it. I think there is a new paper as well looking at the posterior fossa volume and correlating that with the formation of syrinx and the improvement that the children that had a small posterior fossa volume that you did the cervical medullary decompression or Chiari decompression, those are the ones that improved rather than the ones that had a normal posterior fossa volume. I think I think it exists, but I don't have that many patients in my practice that I can draw any firm conclusions on. I think we as practitioners should be open-minded about that and not just jump into a conclusion if you see a normal appearing posterior fossa or a tight one and say, by classic definition this doesn't reach the criteria. I think those are the ones that may warrant cine flow studies and a closer assessment of their symptoms and a frank discussion with the patients or their families if one's going to proceed with the surgical route.
And in the patients that you have with hydrocephalus, do you shunt the patients or do you do endoscopic third ventriculostomies? The ones I've done, I've always started out with an endoscopic third ventriculostomy to see if they'll relieve their symptoms or even their radiographic findings. I've also done the other where some of the children that have had large ventricles and the Chiari with the syrinx, I've done the Chiari decompression and I've monitored their intracranial pressures for a few days after the decompression to ensure that it was just ventriculomegaly without raised intracranial pressure. So I've done both. I try not to place a shunt in. I try to place a shunt in as the last resort, though. Thanks. And then you touched on about bony decompression or no bony decompression in the first instance. I did some work with Ms. Petteroni on using ultrasound, but I know your team had done an extensive study of using ultrasound to assess the adequacy of bony decompression. How much of the ultrasound you'd use intraoperatively nowadays?
So I think what we did when I was in Baltimore was if we did a bony decompression, we always used the ultrasound to assess the pulsations in the flow. And there's been there's been discussion in terms of what kind of modalities of ultrasound do you use, color flow Doppler versus B mode versus M mode. And so when we did just the bony decompression, we always assessed it with an ultrasound. If we were planning on doing the duroplasty, we didn't rely on the ultrasound as much. So bony decompression, we would do an ultrasound if we felt that we could see the CSF flow and that the tonsils weren't as pointed after the bony decompression. We would stop right there and watch us. But from our papers that we published, we found that the patients that underwent the bony decompression their time to improvement was longer, and also the recurrence of some of their symptoms was more significant than when we did a duroplasty. So that was our personal experience in Baltimore.
And in terms of in the intraoperatively, do you use neurophysiology, any maps, any what do you call motor evoked potential or so?
It's interesting. If it's a classic Chiari, no. But I also I've done a fair number of Chiari decompression or cervicomedullary decompressions for the achondroplasia or the skeletal dysplasia children, and I always use neurophysiological monitoring for those. So classic Chiari 1 malformation, no. Chiari 2 malformation, yes, I will use it. Skeletal dysplasia, yes, I will use neurophysiological monitoring.
And in your in terms of the post-op, how much what we call the chemical meningitis is something that you on your side of the Atlantic also have and give steroids, or is this slightly on the voodoo side?
No, I think it does exist, and I've seen it. And I tend to, if I do a duroplasty, and especially if I shrink or coagulate the cerebellar tonsils, I'm more likely to see it. And those are the children I will keep on a slower taper of steroids. Bone decompression, no steroids. Duroplasty, a short course of steroids while they're in the hospital. If they develop symptoms, then I will restart their steroids after ruling out infectious etiology, because these children can spike significant fevers several weeks after surgery.
And in terms of the post-op hydrocephalus, the Liverpool team reported, I think, about 15% post-op. 15% of the patients recurring shunts post-operatively, if I'm correct. Do you have, in terms of your numbers, do you see how many of the patients that you initially thought didn't have hydrocephalus post-operatively end up having VP shunts?
We're actually looking at that in our large number of children, and the prelims it's probably a single-digit percentage point for hydrocephalus. I think it's like probably 2 to 3%, if that, which is different. And again, it's what are the criteria and what do we do?
In terms of the prognosis, in terms of even when it looks pretty classical Chiari malformation, not all the kids get better. The literature says about 90% of the patients get better, but realistically, my feeling is less than 90% in most practices. Why do you think that patients with classical Chiari do not necessarily get better after foramen magnum decompression? Do you have any thoughts on that?
Yeah, I think when we looked at our data, looking at the symptoms that improved, I think we were able to say that close to 90% plus of the headaches will resolve. And I think it's really how classic are their symptoms? Is it tussive, exercise-induced occipital, or cervical headaches versus the frontal headaches? I will tell you, I don't believe that frontal headaches will improve with the Chiari decompression. It's the exercise or the Valsalva-induced occipital headaches, and that's the ones where I think we get 90% improvement. And if they don't, again, then you start looking for other etiologies such as tension headaches or other possibilities as well.
Last few questions. In terms of, I recall that Dr. Park from Missouri was running a registry for Chiari patients. Do you know where we are with that? Is that still going on?
Oh, it's still active. The registry. We are participants of the registry. There's a new arm looking at prospectively the difference between a bone-only decompression versus the bone with a duroplasty for the children with Chiari and syrinx. So I think it's too early to say what the results will be, but I look forward to seeing those as it's a multi-institutional study.
Have any publications come from that registry yet, or is it still?
There's been several abstracts from it. I don't know. There might be one publication I'm aware of that's come from it, but there hasn't been that many, although they have a large volume of patients.
Thanks. The last question, if I may ask, is there any consensus document on, like the Delphi consensus on what might be the best procedure or what might be the accepted procedure by a majority of neurosurgeons for Chiari? Or as you said in your talk, that there's too much variation in those surveys.
I think there's just too much variation. I mean, I think, I look at our center alone with pediatric neurosurgeons. We all do the same operation, albeit differently. So we can't even agree amongst 4 surgeons what is the best operation. And all our results are very good. I don't think any of us have any different outcomes. And for that reason, we continue to do them individually. So I think, the verdict's still out. We'll see.
That's great. Thank you very much, Dr. Jallo, for your excellent talk and for answering so many of my questions. And it's really been a pleasure and privilege. And I'm sure our Listserv members will be very grateful and will find your talk, your lecture very useful. Thank you very much.
Thanks, Darren. I look forward to more questions and answers about this condition. Have a good day.
Thank you.